The Genuine Article. Discussion and commentary based on articles from JACC.
Hello, I'm Tony DeMaria, the editor of JACC, and I'm here with Dr. Barbara Drew, who's a professor of cardiology at UC San Francisco and the lead author of an important paper appearing simultaneously in JACC and in Circulation that deals with Torsades de Pointes. So, Dr. Drew, can you tell us what motivated this scientific statement?
The American Heart Association feels that many patients are being monitored in hospital settings without knowledge by the people watching the monitor that they may be at risk for developing Torsades de Pointes. So we wanted to put out a paper with our recommendations for monitoring these patients and telling them the signs to watch for.
Well, I guess that would begin with identifying patients that are at risk for torsade. How do we do that?
Well, there are many risk factors, such as female gender, advanced age, electrolyte abnormalities, severe bradycardias, getting QT prolonging drugs, more than one type, administering it in the intravenous form. So there are a lot of an underlying heart disease.
Sure. So these factors are very common in our hospitalized patients. And how do we monitor to determine if a patient is likely to have torsade?
Well, we should be monitoring increases in QTc interval following the start of a QT prolonging drug. We consider an increase of 60 milliseconds to be significant. And the magic or the threshold which we feel is critical is a QTc over 500 milliseconds. If that happens, then we look for other signs like macroscopic T-wave alternans, exaggerated TU morphology changes in a beat following a pause.
So it's really important to focus on the electrocardiogram. One of the things I really liked about the article was that you provided a list of all the drugs that have been associated with QT prolongation and torsade, and that's available online if I'm not mistaken.
Yes, it is. The University of Arizona maintains an updated list of torsadogenic drugs, and it can be found at www.qtdrugs.org.
Now, sometimes it's difficult to distinguish torsade from ventricular fibrillation. Are there some ECG findings that are particularly valuable?
Yes, torsade is slower than idiopathic ventricular fibrillation. It's in a rate range of 160 to 240. It usually has a warm-up phenomenon with the first few beats being slower. It often spontaneously terminates, unlike VF, but it can degenerate into VF and cause cardiac arrest. It is also a key finding of torsade is that it is triggered in the beat following a pause, which is generally the pause due to a compensatory pause following a PVC.
So if we're monitoring our patient and we see some QT prolongation or perhaps even torsade, the recommended treatment would be?
Well, certainly to discontinue the culprit drug, to administer magnesium intravenously, and usually 2 grams is given and it can be repeated. One wants to replace potassium to sort of super therapeutic levels. And of course, the patient needs to stay close to be in a unit where the highest level of monitoring is available with defibrillation.
Well, I've really learned quite a bit from this manuscript. The patients we take care of in the hospital are often particularly at risk for torsade, and the importance of monitoring the QTc carefully really can't be overemphasized to act on that as quickly as possible. This will be an important document, and thanks very much for contributing it to the literature.
Thank you.
For the Genuine article, I'm Tony DeMaria.